Hey everyone, and welcome to this explainer on mastering lung ultrasound. Today, we're unlocking a vital bedside skill that literally outperforms traditional chest x-rays. And the crazy part is, it does it in mere seconds. If you've ever felt that absolute frustration of waiting around for imaging while your patient's respiratory status is rapidly changing, well, this is going to be a massive game changer for you. Picture this typical workflow. A patient is suddenly short of breath, you order a chest x-ray. You wait for the tech, you wait for the machine to get positioned, and then you wait for the read. Time is literally ticking away. But what if you could confidently diagnose almost any lung pathology in seconds without waiting for an x-ray at all? That's the sheer power of Point of Care Ultrasound, or POCUS. It's honestly like giving yourself x-ray vision right at the bedside. So here's our roadmap for today's masterclass. We're going to start with the basics and preparation, then move into the 6-point exam protocol and establish our normal lung ultrasound signs. After that, we'll dive into pathological ultrasound findings, figure out how we're diagnosing major lung diseases, and wrap the whole thing up with a summary of the Blue Protocol.
All right, let's kick things off with Section 1, Basics and Preparation.
You know, just getting your setup right is half the battle here. Simple ergonomics will drastically improve your image quality. Step 1, position the patient supine and have them raise the arm of the side you're scanning right behind their head. This nicely opens up those rib spaces. Step 2, grab your probe. A curvilinear or phased array probe works perfectly for a general exam, though actually a linear probe is great if you just need a really shallow view of the pleura. And step 3, park the ultrasound machine on the patient's right side. This lets you scan with your right hand and comfortably tweak the machine's buttons with your left. Moving right along to Section 2, the 6-point exam protocol. Think of the chest like a map. We divide each side into 3 distinct zones. Points 1, R1 and L1, are up in the anterior superior chest, right at the mid-clavicular line, second intercostal space. This is your prime real estate for spotting a pneumothorax or interstitial edema. Points 2 are lateral, hitting the mid-axillary line around the 6th or 7th intercostal space, perfect for checking general lung sliding. Finally, points 3, which we also call the PLAPS points, are posterior inferior. You slide the probe under the patient to the posterior axillary line. Why? Because that's exactly where gravity pulls fluid, making it the absolute best spot for detecting pleural effusions and consolidations. Okay, Section 3, normal lung ultrasound signs. What does healthy actually look like? The very first thing you want to hunt for when you place your probe on the chest is the Batwing Sign. Finding this confirms your anatomy. You'll see 2 dark vertical shadows. Those are the ribs, basically blocking your sound waves. And spanning the space right between them is this bright, horizontal white line. That is your pleural line. It literally looks like a bat's wings. If you don't see this, adjust your hand, because you aren't properly anchored between the ribs yet. So once you've found that pleural line, you need to look for a movement. You're looking for the visceral and parietal pleura sliding against each other as the patient breathes. If it's kind of subtle, just flip on M mode, motion mode. A healthy lung gives you what's called the Seashore Sign. You get these straight lines at the top representing the static chest wall, think of that as the sky and the ocean, and a grainy static-like pattern below the pleural line representing the moving lung, which is your sandy beach. But if that sliding stops, like in a collapsed lung, the whole image just turns into parallel horizontal lines. We call this the barcode sign, and it means lung sliding is totally absent. Not good. All right, our final normal baseline sign is the A line. Because normal lungs are just full of air, the ultrasound waves get completely scattered and bounce back and forth between the pleura and the probe. This creates these cool reverberation artifacts called A lines. They look like bright, horizontal lines repeating at equidistant intervals deep down into the screen. Seeing A lines paired with normal lung sliding, that tells you the lung tissue right there is perfectly aerated and totally healthy. Let's transition to Section 4, pathological ultrasound findings. This is where things get really interesting. Enter the B line. This is basically the visual opposite of an A line. When the interlobular septa of the lung fill up with fluid, you get these vertical, bright, laser-like beams that shoot straight down from the pleural line all the way to the bottom of your screen. They actually obliterate the horizontal A lines as they pass right through them. B lines mean you are looking at a wet lung. Now, a stray B line here or there, totally normal. But seeing more than 3 in a single field of view, that's a major red flag for interstitial edema. You'll notice lung pathology comes with a really rich set of visual metaphors that make it instantly memorable. For example, if a lung infection causes a subpleural consolidation, the border where the fluid-filled tissue meets the normal aerated lung looks completely jagged and torn. We call that the shred sign. If there's a pleural effusion down at the bases, sound waves suddenly travel right through that fluid, letting you clearly see the vertebral bodies of the spine extending past the diaphragm. That's the spine sign.
In massive effusions, a dense consolidated lung might literally flap around in the fluid as the patient breathes, looking exactly like a swimming jellyfish. Yep, the jellyfish sign. And finally, if that pleural fluid is exudative, meaning it's full of protein or infection, you might see the swirling white debris inside it. We call that the plankton sign.
Before we leave pathology, I've got a rapid clinical cheat code for you. The magic number is 20. If you find a pleural effusion in a supine patient, just measure the maximum diameter of that fluid pocket in millimeters. Multiply that number by 20, and boom, you instantly have a highly accurate estimate of the total fluid volume in milliliters. It's an absolutely incredible tool for making rapid drainage decisions right at the bedside. Moving on to Section 5, diagnosing major lung diseases. Let's put these pieces together. Listen, when it comes to pneumothorax, ultrasound is your absolute best friend. Here is the golden rule. If you see lung sliding at a specific point on the chest, you can rule out a pneumothorax at that exact spot with 100% accuracy. The pleura are touching, end of story. But if sliding is absent, don't jump the gun quite yet. It could be a massive consolidation or even severe COPD. To rule a pneumothorax in with 100% certainty, you absolutely must find the lung point. This is the exact transition zone on the screen where the normal sliding lung meets the static, collapsed lung. Find that lung point, and you've made your definitive diagnosis. Now, POCUS can also seamlessly differentiate between two conditions that often look identical on a standard X-ray, pneumonia and atelectasis. Both creates a dense, consolidated, fluid-filled lung. But here's the trick. Look closely at the tiny white specks of trapped air inside that consolidation. Those are your air bronchograms. If those white specks move back and forth as the patient breathes, they're dynamic. That means the airway is open, pointing directly to pneumonia. But if those white specks are completely frozen and static, the airway is blocked, and that points directly to an obstructive atelectasis, like a mucus plug. So how do we tell the difference between causes of severe shortness of breath? We use this diagnostic matrix right here. If a patient comes in with congestive heart failure and elevated left heart pressures, that fluid backs up symmetrically, right? So you're going to see widespread bilateral B lines in every zone. But if the patient has ARDS, maybe from severe sepsis, the capillary leak causes a patchy wet lung. You'll still see B lines, but they might be totally asymmetrical or even unilateral. What if the patient has a severe COPD exacerbation? Well, their lungs are hyperinflated but dry. You won't see B lines at all. Instead, you'll see a completely dry lung profile with A lines everywhere. Though keep in mind, the lung sliding might be reduced just because they are taking such shallow breaths. Finally, let's wrap up with Section 6, the Blue Protocol Summary. So the Blue Protocol basically categorizes our findings into 5 easy-to-remember profiles for acute respiratory failure. The A profile gives us normal A lines and normal sliding, so a dry lung, perhaps pointing to COPD or a pulmonary embolism. The B profile shows B lines with normal sliding, heavily pointing toward pulmonary edema. Now pay attention to the prime symbol here, the apostrophe. That means impaired lung sliding. So a B prime profile is a wet lung with impaired sliding, strongly suggesting an inflammatory pneumonia. An A prime profile is a dry lung with impaired sliding, waving a massive red flag for pneumothorax. And an A/B profile means one lung is dry and the other is wet, a classic textbook presentation for unilateral pneumonia. It is just a brilliant, feel-proof toolkit. Well, we've covered the physics, the positioning, the signs, and the algorithms. You now possess a rock-solid foundation of ultrasound X-ray vision. The only question left is, how are you going to integrate this 6-point exam into your actual clinical practice? The very next time you get called to a rapid response for acute hypoxia, are you going to stand there waiting for the portable X-ray machine? Or will you grab that probe, look for those A and B lines, and diagnose the patient yourself in under a minute? Dive in, practice on your next shift, and let this technology completely transform how you care for your patients. Thanks for joining me on this explainer, and keep learning.